Hello, welcome to UOA On Demand. My name is Dr. Michael Liu, shoulder elbow orthopedic surgeon at University Orthopedic Associates. Tonight we'll be discussing medial epicondylitis and lateral epicondylitis of the elbow. Joining me on the call, we have Dr. Ryan Coyle, a hand upper extremity orthopedic surgeon, and Dr. Chris Doumas, a hand upper extremity orthopedic surgeon as well. Gentlemen, thanks for being on the call.
Good evening.
Thank you.
So, Dr. Doumas, why don't we start with some basic elbow anatomy, maybe the bony anatomy, the soft tissue anatomy about the elbow.
Sure. So we can focus mainly geared towards what we're doing and what we're going to discuss tonight. So, epicondylitis is the most common problem that we see in the elbow for a cause of office pain. It can often be confused with some underlying joint and bony problems as well. But basically what we're looking at is the upper arm bone or the humerus bone. And that comes down and articulates at the elbow here with two different bones. One part of the ulna, which is the long bone that basically flexes and extends at the elbow joint. And there's another one called the radial head, which is part of the radius, which is the forearm bone that rotates at the elbow. So those are basically the three bones that come together at the elbow joint. There are some complex ligaments that come together there, as well as some tendons that attach at the bony prominences, both on the inside and the outside. And that basically leads us to kind of get into where our tendon pathology comes from for golfer's elbow and tennis elbow, or medial epicondylitis and lateral epicondylitis.
Yeah. So Dr. Coyle, Dr. Doumas alluded to some of the soft tissue structures about the elbow, particularly the tendons about the elbow that are important for medial and lateral epicondylitis. Can you tell me more about those?
So, both the inside and outside parts of the elbow, the medial and lateral side, have a structure called the epicondyle, and that's where the tendons, the tendon origins of a bunch of the tendons that flex and extend the wrists and fingers start. So this is what we call the common flexor and extensor tendon origins. So those are basically the most prominent points of the epicondyles, where the most prominent part of the bone. And those parts of the bone have a little bit tenuous blood supply. So if there is any sort of overuse injury or direct trauma, there's a little bit, I tell patients, a little bit harder to heal any sort of strain or sprain in that area. And that's why people can get prone to chronic tendon problems in this area, which is what our, the problem that we're going to discuss tonight kind of is all about.
Yeah. I think one thing we kind of glossed over is the medial side is the pinky side of the elbow, and then the lateral side is the thumb side of the elbow. We talked about lateral epicondylitis. We're talking about the bony prominence on the outer side of the elbow, and then medial epicondylitis is the bony prominence on the pinky side or the inner side of the elbow. So Dr. Doumas, who gets medial or lateral epicondylitis?
Everybody, myself included. I've had both, and it certainly seems in the office sometimes like everybody and their mother gets it. So it's a very, very common problem. Tennis players, and which is why we call it tennis elbow, do get somewhat a more extreme or more common scenario when you get pain on the outside of the elbow. But I see far more patients who don't play tennis than do play tennis that end up with tennis elbow, and I see far more people with golfer's elbow that don't play golf. It's usually from repetitive things. So, from a personal standpoint, I got golfer's elbow from my older son was 3 years old, and I had to lift him around in a long leg cast, and I ended up with golfer's elbow with pain on the inside of my elbow from doing overuse lifting for him for the 4 weeks he was in a long leg cast. I've also had tennis elbow on the outside of the elbow as well, again, from overuse injuries. So anybody who does a lot of repetitive motion, especially with gripping, where you're trying to stabilize your wrist, so that's where a lot of this comes from, is a lot of repetitive lifting. So whether it's palm up or palm down, we'll go into as we go further into each different side in the pathology.
Right. So sports can play a role, occupation can play a role, hobbies, anything repetitive, a lot of gripping. And those people, because of overuse, repetitive use, can get these types of problems. Fair to say?
That's correct. It's also very frequently found in the traumatic population, just from having a fall. Where you land on the arm. Some people break the wrist. Some people rip a little bit of tendon off of their elbow on either the inside or the outside as well. So,
Sure. So Dr. Coyle, what are some of the symptoms that people will come in complaining about when they have golfer or tennis elbow?
Well, I think the first and foremost problem is pain. And it tends to be sort of an aching, dull pain. Now, on the inside of the elbow, the pinky side, there is a nerve that runs right in that same area. That is a little bit, sometimes it's a little bit confusing to kind of parse out whether a patient's pain is in any way related to nerve symptoms versus just tendon problems. But in general, tendinitis in this area, it's a dull ache that is very deep and bothersome, but it's not, in my experience, this isn't something that people come in with the first week or two. It tends to be a presentation of, I've had this problem for 6 weeks or 2 months and it just hasn't gone away and it's been bothering me. And it tends to get worse with activity, but it can, bother people throughout the day. Every once in a while, people also complain of numbness and tingling with lateral epicondylitis too, because with severe swelling in that area, there can be a little bit of nerve entrapment of a nerve called the radial nerve that's in that area. But primarily the symptoms are not as much nerve related, but pain and sometimes weakness secondary to pain. That's what I found.
Yeah, I think it's a good point. I've noticed that a lot of patients will come in after they've had this type of pain for months, and it's usually because it's not a severe pain. They're not saying it's 10 out of 10 pain, but they say, well, it's kind of achy, kind of nagging, kind of annoying when I do certain activities, but they just live with it for the most part. And then months go by and they realize, well, it's not gotten better, maybe I should get it checked out. And usually that's, a pretty clear indication that it's a repetitive overuse kind of pathology as opposed to something traumatic or, something torn from an acute issue right away. So Dr. Doumas, what kind of physical examination findings are you looking for when you're trying to diagnose these problems?
Sure. So most common is just the tenderness, the point tenderness that you have either over the outside, the bony prominence right over the outside of the elbow, just basically right up here, or on medial epicondylitis on the inside, right over the bony prominence in through there. Now, there are other things that attach to those bony prominences, such as ligaments and such. But it's more typically when you're doing wrist flexion or extension exercises with resistance. And so I'll have the patients basically straighten their arm out, cock the wrist up to the ceiling. If they feel pain on the outside of the elbow, that's pretty classic for lateral epicondylitis. With wrist flexion exercises, flexing in this direction with resistance again towards the palm side, that usually causes pain on the medial side during medial epicondylitis. Also with forearm rotation, you can also get those symptoms. Again, for pronation, you'll have that on the medial side or the inside of the elbow. For supination, sometimes that can be associated more with the lateral side for rotating the forearm palm up in that direction. So sometimes there's a little bit of swelling that's present there. Sometimes there can be a little bit of prominence that's present over the bony prominences as well, because you can sometimes get a little extra calcification in a chronic version of this, and you'll see that on x-rays. Those are the main things.
Great. Dr. Hoyle, so Dr. Doumas alluded to getting x-rays as one of the first tests that we would do in the office. Would you order anything else routinely besides x-rays?
I don't, if not for an initial examination. I think with anybody's had pain for more than, a couple months, x-ray is helpful just to rule out, any more serious bone pathology or any other associated degenerative problems of the joint. But, I'd say probably 90% of tennis elbow or golfer's elbow patients that come in really don't have any findings in the x-ray. And with the exception of every once in a while, you get some soft tissue calcifications in the area, but a tendon pathology that's just failed to heal. Ultrasound can be helpful, but again, it doesn't add too much to the picture in general, unless there's a really detached tendon tear or some sort of large, seroma or fluid collection. An MRI will generally show pathology. It will confirm the diagnosis, but by and large, for most patients that are coming in, an MRI is not really helpful because, as we'll get into later on, I'm sure this is a self-resolving problem most of the time, and an MRI doesn't. You don't need an MRI to make the diagnosis and to tell people that it's likely to go away on its own.
Yeah, I think it's a good point. A lot of patients come in, they are looking to get an MRI done. And like you said, oftentimes they don't need the MRI because it won't change your treatment algorithm. So by and large, people will still get better with time, various treatments that we'll discuss later on. And oftentimes an MRI will find an additional finding, partial ligament rupture or some other sort of finding that you wouldn't really treat otherwise because it's not symptomatic. So it just makes the picture a little more muddled. So we mentioned some other possible diagnoses that can be confused with medial and lateral epicondylitis. Dr. Doumas, what are the kind of problems can mimic these types of tendonitis about the elbow?
So as Dr. Cole already alluded to, there's some nerve issues that can be associated with this. There are joint arthritis problems that can be associated that are similar, because you can have tenderness both over the inside of the joint as well as the outside of the joint. You can, again, see with those types of things on regular plain x-rays. Basically, on your examination, you can also tell if there's any ligament tears or injuries just based on some of the stress exam that you'll do in the office. So you can have a medial collateral or a lateral collateral ligament injury. There are biceps problems, and that usually gives you pain more in the front, or what we call the antecubital fossa. I'll try and bring it up here, but it's more in the front on the outside as well, and that's commonly associated with it. Usually you can tell the difference with that based on some of the supination, when you resist the supination, and just some of the area where they have point tenderness, but it's a really common thing to get as well, distal biceps tendon problems. And there's a little bursa that lives around there as well, and that can frequently get inflamed, so that can get confused as well.
So Dr. Coyle, what would you do if a patient comes in, never had any treatment for their epicondylitis problem? How would you start?
I think the most important step is, explaining to the patient what's wrong and kind of reassuring them that a lot of the time people don't know what's wrong with them, and they're concerned because it's been 6 weeks, 2 months, 3 months. The people want to understand that nothing serious is going on and that this is likely to get better on their own. So first and foremost, we talk about the fact that the vast majority of these are likely to go away on their own within 6 to 12 months, regardless of what you do. So certainly nothing more than a course of possible physical therapy versus home exercises. The Academy of Orthopedic Surgeons has a nice printout, which is accessible easily on Google, with just a series of 5 to 10 stretches and basic exercises you can do at home. And then you can also consider wearing what's called a counterforce brace, which will squeeze the muscles that are affected to offload the tendon origin. Anti-inflammatories by mouth. Those are all good, basic steps to start out with. Certainly don't get MRIs unless a patient has had more than a year of pain or has had other treatment before. And there's no point to go down the same road that they've already tried.
Dr. Doumas, what are your thoughts on injections for tennis elbow or golfer's elbow?
Sure. So, it varies. And I always explain to my patients that if your pain is so severe that you're having difficulty, working, functioning, things of that nature, injections do play a role and they can be helpful. There's various kinds of injections. You have steroid injections. People have injected botulism toxin into the tendon to try to help with the pain. There's platelet-rich plasma, which is also a very commonly performed injection for the epicondylitis, both on medial and lateral sides. I'm not a very big injector. I always explain to patients that, it can be helpful. And I've had patients that have gotten better from my shots over the years, but I try to avoid doing that because what I explain to them is every time you poke a hole into that tendon or in that area with a needle, you're creating a little bit of a micro tear, right? So you're creating a smaller hole there. So, and the steroid gradually over time, if you have repetitive injections, will break things down further. And that's what the type of steroids that we use can do for that. So I'm a big fan of trying the wait and watch approach, teaching a home exercise program with stretching and the counterforce straps. And unless it's absolutely mandatory because the patient's really that uncomfortable, I really try to avoid the injections at the first visit and the second visit if necessary, to try to keep them away from causing chronic problems. The injections, if you look at some old literature, do have a higher recurrence rate compared to the watch and wait, see what happens and with physical therapy. So I really try to avoid them,
I think it's important to note that even if you do get an injection for your tennis elbow or your golfer's elbow, it's still somewhat of a Band-Aid. You still need to do the therapy, still going to wait it out. It's not a quick fix because it's still a long-term sort of problem that you have to wait for the pathology to resolve.
I agree. And what I find is that typically the people who have the injections, it works for 3 months, and that seems to be the magic number. And then it's right back again. And then they're looking for another injection. And again, the more they do it, again, anytime you go in there with a needle, I find that, those patients that have the injections tend to come back if they've had repetitive ones with more lateral ligament issues and things of that nature down the line on their MRIs that need to be addressed. So,
yeah, that's a good point. And also, if you do cortisone shots, it can play with blood sugars for people who are diabetic. So it's another important factor to keep in mind as well.
Absolutely. I also mentioned previously that there's, platelet-rich plasma injections, which is where you take your blood, you draw it out of the patient, we spin it down in a centrifuge, and you take an area of the blood that has, more growth factors to it. And, I'm not sure the jury is completely out yet, but some of the more recent literature shows that there's not necessarily a huge amount of support behind doing that as well. It's typically not covered by insurance either, so it is paying out of pocket. So I kind of explain to people it's almost like rolling the dice as to whether it's going to help or not. That being said, some people I have done them on and they do get better, but it's certainly not my first line treatment.
Yeah, I agree. I find that it's somewhat of a mixed bag. So Dr. Doumas, another possible treatment option to consider for tennis elbow especially would be the 10X procedure. Can you talk to me about that?
Sure. So there's a couple of different devices out there that are utilized for a percutaneous treatment. And what that means is basically just do a small incision. So, we're talking about when you do open surgery, you're talking about, a decent incision somewhere, 3 centimeters, 4 centimeters, depending on what you're going to be performing and doing. One of these procedures are the percutaneous guidance procedures. It's an ultrasound guidance procedure. You're doing it basically through a small little stab incision, about 5 millimeters. I do them wide awake local in the office using ultrasound guidance. And basically, in essence, what happens is you're passing a probe into some of the diseased tissue. You identify that on an ultrasound probe with one hand. You kind of keep that centered where you need it. You make the little incision after you numb everything up. And once the patients are comfortable and everything like that, then you basically make a little incision and you're able to then pass the probe without pain into that region. I almost explain it to patients as it's almost like you're vacuuming it out. But basically, what the tip of the probe does, it emulsifies the tissue and it irrigates and basically squirts some water in and sucks it back out at the same time. So it's almost like, you're destroying and emulsifying the tissue and vacuuming it out. And so I tend to do that only in patients who have more mild disease. I've found, although I've had very great success with it with those patients, I had a couple of patients where they were more significant on the MRIs. And I first found out about it because I had a patient who had brought their MRI in after we did the 10X because she finally found it. And I was able to see that it was pretty extensive. So, it was read as mild, but when you actually looked at the images yourself, it was sort of misread by the radiologist. And so, I've been a little bit more aggressive getting the MRIs on those patients to make sure that it's just more mild disease present as opposed to more moderate or severe or when they have partial tearing, because those I don't think are as amenable to a percutaneous treatment option. So for mild disease, I think it works very, very well. And I've had great success with it. For more significant disease, if there's partial tearing, again, questions of ligament injuries and things of that nature, then it's definitely not, I take it off the table for that. I have not had great success with it with medial epicondylitis on the inside of the elbow. I've had very good success with it for lateral epicondylitis. So I really don't offer it for golfer's elbow. So I personally find there's a very different tendon architecture on the inside of the elbow versus the outside. And I think that definitely plays a role.
What can a patient expect for recovery after the percutaneous procedure?
So for that, basically, I put them in a sling. I put them in a little dressing that's waterproof. I let them start to move right away. I've done, a couple people in our office and they're back to work the same day, basically using and moving the arm as much as they can right off the bat. So it's definitely a much quicker recovery than for an open procedure. So.
And you would allow laborers to go back to work right away as well?
Not necessary for more desk work. So.
Okay, all right, great. Dr. Coyle, what are some other surgical options that we could talk about for tennis elbow first?
So when you're talking about actual surgical procedures going to the operating room, generally you're making some sort of incision. Now, arthroscopic debridement of tennis elbow. So the tendon that's generally irritated or bothered in this condition is what's called the ECRB tendon, or extensor carpi radialis brevis, and that's a long term for basically a region of the tendon that tends to get inflamed and shows this sort of the medical term is what's called angiofibroblastic dysplasia. What that basically means is an inflamed abnormal portion of the tendon, and it looks swollen and purplish if you look at it grossly. That part of the tendon can be debrided from the inside out using arthroscopic instruments, which are essentially instruments that are put into the joint through keyhole incisions and then debrided out. Now, that in my hands is really not as efficacious or quick as just making a small incision a couple centimeters over the tendon origin and identifying the tendon that's diseased and then removing it. And the big question is, so what do you do with the cavity that's there? Generally, there's some amount of tissue that you have to take away that leaves a hole. So is there a need for tendon repair? I'm not sure that there's a great answer for that. In general, I think if an MRI shows a big tear, prepared to fix it as after doing debridement. But the general surgical thought is that both for medial and lateral epicondylitis, that diseased tendon at the origin has got to be removed. And then by stimulating some bone bleeding in the area, whether using a drill or just debriding the bone surface, the fact that you're generating bleeding generates a healing potential and really gets the problem to resolve pretty quickly.
So Dr. Coyle, what can a patient expect in terms of recovery following an open procedure?
So I tell my patients that in the first 2 weeks or so, you're going to hate me, that the pain is going to be worse because you're generating a healing response. This is a nagging pain, and it becomes a quite, aching, more profound pain for the first at least 7 days after surgery. So I usually put my patients in a splint, at least at the wrist to keep the wrist still, because again, the wrist and the fingers are the tendons that essentially are governed by the medial and lateral common flexor and extensor tendons. I don't really let people go back to any sort of heavy labor or lifting for about 6 weeks after the injury. I generally have them in physical therapy doing some light isometric exercises and other stretches, but patients are not really comfortable going back, with the exception of the rare patient that will just get themselves moving earlier on. But I generally counsel people to not do anything heavy for about 6 weeks at least.
Mm-hmm. Dr. Doumas, do you do arthroscopic debridement?
I do it when I'm thinking that there may be some other reason to be in the joint. So it is rare that I'll do it through the scope arthroscopically. Typically, if I'm feeling any type of mechanical symptoms on the outside of the elbow, if I'm concerned that there may be like what we call a synovial plica, which is basically an infolding of the capsule. If there's any type of lucency or any type of injury to the cartilage along those lines, if you have a loose body that needs to be seen, or if there's any need to assess any of the ligamentous structures. But routinely, I do more of the percutaneous, or I do more of the open procedure.
Would you counsel your patients any differently in terms of prognosis or recovery after an arthroscopic procedure versus the open or percutaneous?
So philosophically, that's where I also come into play, is when you're doing it through a scope, you're basically debriding or releasing or cleaning off that tendon. When I do my open procedure, which I do for the majority of the patients that get to that point, I do believe in trying to restore the anatomy and repairing that. So I do a formal release of the tendon and clean off the diseased tendon, but I actually do repair the majority of my extensor tendons back as well to the bone, which I can't do through a scope. And so therefore they are splinted for a little while with that. And I just found that it worked best in my hands. So
splinted at the elbow or at the wrist?
I do an elbow sugar tongue splint. So it basically goes from the hand around the elbow and back to control both the elbow as well as the wrist.
And how long would they wear that for?
I do it for 2 weeks, and then when they come in, they get their stitches out, and then I get them moving at the elbow, but I still immobilize the wrist in a brace for an additional 2 weeks, and then I have them work on stretching on their own at that point.
Okay. Dr. Doumas, can you tell me about how you would treat medial epicondylitis through surgery as well?
So from once non-operative fails, from the medial side, again, a different tendon architecture than the outside of the elbow. It doesn't get talked about a lot. There's not a lot written about in the literature. When I first came into practice here, one of the first patients I saw was somebody who couldn't find anybody in the area that did medial epicondylitis surgery on the inside of the elbow. It seemed kind of silly to me, but it's more bread and butter upper extremity surgery. So, I basically do a debridement there. I rarely do a repair on the medial side. It's a very different tendon architecture because it's not just about releasing the tendon and cleaning off the diseased tendon from the epicondyle. There are basically these septae or walls inside the tendon is the best way to describe it. They're basically thickenings of the tendon that if the outer coating is this way, these bands are running more in this direction. And so it's important from my standpoint to remove those as well to alleviate the pain. So.
Okay.
I do a similar post-op period as well because I do want things to heal back in. And I like to get that body to respond and scar in. So.
Great. Dr. Coyle, any other differences in how you might treat medial epicondylitis with surgery?
That's not amenable in most cases to any sort of arthroscopic procedure. So you are doing this open. But I generally find that if there's a big area of diseased purplish tendon that, I will try to take it out. And if there's a cavity there, like Dr. Doumas mentioned, I do usually place an anchor. Although I do find that, that I think that there's not really a good answer whether that's necessary or not. And with most literature on surgical treatment of epicondylitis really shows that the patients do well no matter what you do. So when there are multiple different ways to address a problem, that generally shows you in medicine or surgery that, a lot of them work. But I basically almost always approach these open. It's quicker. As long as the patient's has gotten to the point that they're in enough pain to have surgery, I don't think they are that bothered by a small incision. So I think it's just an easier, and I can feel more confident in having treated the patient properly when I can see exactly what I'm doing and know that all the tissue has been removed that needs to go.
Mm-hmm. Yeah. Dr. Doumas, can you talk to me about every surgeon's least favorite topic, complications from surgery?
Just like any open procedure or any surgery you do, there's obviously always a risk of infection, injuries to blood vessels and nerves. Specifically on the inside of the elbow, there are some little cutaneous branches that are present. They give the sensation to the forearm and the upper arm in this area. So those are potentially at risk. There's obviously nice, easy ways to prevent injuring them during surgery, and that's just by using careful dissection, using blunt instrumentation, and not just cutting down with your knife so that you're cutting the nerves and everything along its path down to those tendons. I always explain to people with this surgery and with most of my surgeries is that you're not coming into me normal. So I'm not making you normal. And that's really the best way I can explain it to them. We're making them different. And so I think once they understand that concept, they understand that, I can't promise you're going to be a 0 out of 10 forever with pain, although that does occur with most of these surgeries post-op. Eventually, some people get there in 6 weeks, some people get there in 3 months. There's still a risk of having some persistent symptoms because it's not a normal elbow. It's not normal tendon at that point. It's different. So as long as people understand that, and they understand that hopefully they'll be a 0 out of 10 for the most part throughout their day, they might still get a little discomfort here or there, and maybe a 1 or a 2 at its worst when you're overdoing things. That being said, I find these are very successful surgeries. I find that the patients love them, especially when they're feeling great at 6 weeks and they literally have no pain. It's a life changer when you've been going on with this for about a year or so in a lot of these patients. Now, again, you can have tendons rip off. You can have fractures if you're drilling holes in the bone, things of that nature. You can get extra bone growth that occur. For most of us, we do little drill holes. Whether you put an anchor in or not and do a repair, usually you're doing some drill hole on the inside or the outside of the bone in order to stimulate a healing response and get some of those blood elements out of the bone marrow that have growth factors in them. So you could get a little bit of extra bone growth with those as well. You also want to make sure that you're not missing an underlying, nerve injury, ligament injury, or joint capsule injury as well at that time. What I find, I think is more intriguing is that very frequently when I see MRIs on elbows for tennis elbow or lateral epicondylitis, the radiologists often miss some secondary signs to elbow instability. And I find that that's relatively common. And so I'm always looking for that as well.
Mm-hmm. Yeah, I think it's a good point. When you're in there, you're debriding the diseased tendon. Oftentimes, the ligaments that are stabilizing the outside and the inside of the elbow are just right next door. So, can you have a ligament injury that occurs during surgery? Yeah, it's certainly possible. Not very common, but certainly possible nevertheless. So I think that pretty much wraps up our discussion on medial and lateral epicondylitis of the elbow. So we talked about the bony anatomy, primarily the bony prominences at the outside and the inside of the elbow, where these tendons they originate from, and that causes golfer's elbow, which is medial epicondylitis, which is on the inside of the elbow, and tennis elbow, which is lateral epicondylitis, which is on the outside of the elbow. We talked about how repetitive use, overuse can cause these problems to occur, and it's very, very common. Dr. Doumas gave us his own personal analogy, which was great. We talked about how you can make the physical examination finding with point tenderness right over these bony prominences. You can also have pain with resisted motions of the wrist or elbow sometimes. Usually you don't have numbness or tingling unless you have a neurologic issue as well as the epicondylitis problem. We talked about how x-rays can be important to identify bony anatomy and bony pathology, such as calcifications or arthritis or fractures. MRI can be useful if you're in the preoperative planning phase, but usually not a first line test that you would need to get right away. Talked about other diagnoses that can mimic medial or lateral epicondylitis, things like arthritis or fracture or triceps tendonitis, biceps tendonitis, or bursitis, a number of these different problems, ligament injuries. Spoke about the non-operative treatment options, which would primarily be rest, avoiding painful activities, account for brace, anti-inflammatories, physical therapy program. We also briefly touched on corticosteroid injection and platelet-rich plasma injection. We spoke about the percutaneous treatment options, which is the ultrasound-guided debridement or the vacuuming procedure. And we finally spoke about the operative treatment options, the arthroscopic debridement or open debridement plus minus a repair. And then we spoke about the complications possibly associated with surgery and the likelihood of success, whether you have surgery or don't have surgery, because most people will get better without surgical treatment. It's just a matter of how long you're willing to wait. And then the people who do have surgery, by and large, they get better as well. So, gentlemen, thanks for being on this call tonight. And for the people at home, if you have any other additional questions about tennis elbow or golfer's elbow or any other orthopedic ailments, feel free to check us out on UOANJ.com. And you can also look for other UOA on demands on our YouTube site. And we look forward to answering your questions or seeing you in the office if you have a problem. Thanks.